Okay, we are going to go ahead and get started, everyone. So good afternoon and welcome to this month's MillerKnoll Design Perspective, where we will hear from Michelle Ossmann, our Director of Research. Michelle has earned a PhD of Architecture and Culture in Behavior from Georgia Tech University and considers herself a sociospatial scientist, focusing on how human interaction is affected by the organization of environments. Today, she will be sharing our CEU on planning for clinical practice. Please note that there is a form to fill out in the chat if you want to apply for EDAC. This is an approved EDAC CEU. It is currently pending approval for AIA and IDCEC. So if you would like either one of those credits, please fill out the form. We are going to retroactively submit for that credit once that CEU has been approved, which should be shortly. So you'll have to kind of keep posted on that. In terms of the plan for today, construction and planning and design for healthcare requires a unique approach. Building a clinical space that can keep up with the evolving processes and flex with the needs of people in the environment isn't about what you plan, it's about how you plan. The planning process and its associated activities themselves provide long-term success, helping to avoid buildings that don't support the needs of people who use them. Because this is a CEU, if you do have comments or if you do have questions, please place them into the chat. We will hold and Michelle will answer those questions at the end of the CEU. CEU should last about 40 minutes or so we should have plenty of time to be able to ask questions and to have a conversation at the end of the program. Thanks so much. Michelle, I'm going to turn this over to you.
Thanks, Jennifer. Hi, everyone. Planning for clinical practice. I hope you're as excited about this topic as I am. It was fascinating to research and to think about what the planning process has been, what it can mean. Again, as we said, shared before, pending approval for IDAC, pending for AIA, EDAC approved. You have the numbers which we will provide. Copyrighted. Now, forgive me, I am required to read this description since it is a CEU. So, in this course, you will learn about an approach to clinical planning and design that enables self-driven success with an adaptive clinical environment. Effective healthcare construction planning focuses on creating adaptable spaces that evolve with changing needs and practices. Rather than striving for a perfect design, the emphasis should be on flexible planning that allows the environment to adjust to unforeseen scenarios and daily operations. Success is measured by how well the space supports and adapts to the needs of people, with continuous adjustments and learning through the design, occupancy, and practice phases. And I'm required to read this as well. The learning objectives. At the end of this course, participants will be able to, 1, discuss the challenges between programming, design, and clinical practice, and how those impact the well-being of patients and clinical staff. 2, explain the SIPS, the Systems Engineering Initiative for Patient Safety Model, and the associated evidence underpinning participatory design practices in healthcare. 3, to apply utility and usability criteria to assess for design usefulness to ensure the space responds to everyday occurrences that may impact the well-being of patients and clinical staff. And then lastly, formulate novel planning processes to facilitate tending in healthcare. All right, and here we go. So, as we know, construction planning and design for healthcare requires that unique approach. And we know that it's challenging and that building a clinical space that can keep up with evolving processes and flex with the needs of the people in the environment isn't really about what you plan, it's about how you plan, right? We're all versed in this. So the planning processes and activities themselves provide lasting value, not necessarily the plan itself, right? That can change over time, helping to avoid buildings that don't support the needs of the people within. So, when I thought about this question, it occurred to me, well, when did we decide that a building should work? Right? When did we decide that there should be an outcome associated with design? And then what did that mean for planning and design? Many of us work with planners or are planners, right? This function is vital and helps us decide what we need and why. But let's take a step back and ask, where did this idea come from? Right? The idea that we can design a relatively inflexible building and try to accommodate and anticipate the activities. It's rather Herculean when you consider it. It's a curious idea. And Michael Batty, he's a professor out of University College London, rather famous if you're familiar with space syntax. He traces the origin to architect Louis Sullivan's 1896 mantra, form ever follows function, reminding us that the text actually said, where function does not change, form does not change. I encourage you to look for this. You can do a Google search and you can actually find the original documents online. And in his writing, Sullivan, interestingly enough, argues strongly that the functions of an office do not change. He has a whole sort of paragraph commenting on this notion, right? So, and because it doesn't change, form can follow the function. That was critical to the 1-2. The functions don't change, therefore the form can follow it. So the idea that spatial configuration is linked to social functioning, that dominated the 20th century planning processes. And ever since then, we've been focused on optimizing efficiencies. It's Taylorism, right? Things like that. But as we know, an unchanging function isn't the case for offices, and it's certainly not the case for healthcare. Rather, we have a mismatch between what Dr. Batty would describe as what we originally designed for and what its purpose might now be, right? This is the tension that we have to deal with. So let's look at these classic floor plans. I drew these when I was in graduate school as part of a study to think about what is the relationship between the form, right, the plan itself, and the activities that were supposed to take place. So each is a general ward. You can see that we've got the scale on the bottom. Each is a general ward, but completely different in terms of the walking and visibility patterns. We have a straight corridor or ring circulation, the number of patients per room, the number of patients per floor, the location of the supplies, the documentation areas. And so, I asked myself, how might each form respond to the changes in daily care practices, right? And for that matter, Dr. Batty reminds us that the stock of buildings, this is how he puts it, the stock of buildings, the interior components, and the layout of a building have a much longer life than the processes and activities in these environments, right? So each decision informs the mismatch, right? Because the form can't adjust to the function. So, but there's another question here, which is to say, can we truly know the function of healthcare spaces? And I really do ask this of myself. And it's not that we don't know the basic and important functions of healthcare spaces, right? We go to great lengths to understand what happens in healthcare environments. We track paths to the med rooms, we calculate view sheds and walking distances, we diagram the patient experience. But it's the unexpected events and the evolving healthcare models that are the challenge. So, let's think about the scenario. You've planned for a patient call bell going off, right? And the nurse will walk no more than 25 feet to a patient room, right? So in those 25 feet, the nurse pauses for environmental services to come out of a room, realizes a coworker needs assistance because their hands are full and they can't open the door to get to the patient. And then someone asks them where room 2137 is, right? We have in here 3 unplanned interactions within a span of less than 2 minutes. Right? And we know that most clinician interactions are unplanned. In 2009, there was a great hospital-based study with over 117 hours of observation. And the researchers found that up to 56% of the interactions are unplanned. In a 2020 study of primary care doctors, they found that over 50% of the interactions were under a minute. And of course, the patient is waiting, right, while we're engaging in all this. Even so, outside of the unplanned interactions, there are the constant threats to safety. We have to think about needle stick injuries. The workforce has many learners, whether they are floaters or they're new to the profession. Patients and families are learners too, so we can't forget that. We have the known and emerging biological threats. Right? Each care department is subject to patient surges in increasing and variable variety. Right? It's, all these things are coming to play. And then now we have to deal with workplace violence. So we ask, when the function of healthcare spaces is so fluid, how can we ever plan the perfect form, right? I almost find it amazing that we attempt to do this and then have in our mind, oh, once it's done, we're not changing it because we're going to get it right, right? I'm super piqued by this notion. So it can't really be about perfection. And I would argue that it can't even be about getting it right? Because right is a moving target. It's about the planning, thinking through what we have to work with, the people, the processes, the place, and then knowing what levers are available when the unforeseen happens. Now, not every lever is created equally, right? And for some, we can make a firmer hypothesis about the intended outcome because we have evidence, right? We have academic studies and we can have a sense of what this actually means. But let's not make the mistake of waiting for the perfect study, right? Or only deciding that our building works because we did a study. And I often find this to be the case. We design an entire hospital, do one study, and are like, wow, that was magic. It worked great. No, rather, let us think about the useful levers that allow the full team, right? The administration, the facilities folks, the clinical staff, to adjust the building to the evolving care processes. And if we do this right, we can also remove the fear and risk associated with perfection, because it was never really the goal in the first place, right? The goal was always a moving, amorphous being, if you will, that can change, right? The goal ultimately is for people to know what their environment can do and how they can manipulate it to meet their needs, right? And this looks like adaptability and, quite frankly, long-term fiscal responsibility. It's very expensive to make changes later. So more than any other metric, including time and cost, these are the primary measures we use. We're arguing today that the measure of success should focus on the people doing the work, right? Can they move easily from task to task, adjusting and adapting? Can they accommodate the unplanned happenings that regularly occur in the space? Can they make adjustments with minimal change in cost? Can they rebound quickly if there's a changing circumstance? So good planning really thinks about all of these together. And I'm suggesting that this would be a positive way to evolve from this fixed notion to one that is truly a change of mindset. So we're going to go over several notions. The first is under the planning phase, designing together, designing in scenarios, and designing for the everyday. And then in the occupancy phase, continuing to teach, and primarily the practice phase, tending to the building, right? So we're going to address these all together. So during the planning phase, designing together, the planning needs to start with people, right? Taking the time to understand the needs of the concerns who will use the space. We are very familiar in healthcare with the idea of designing with people, not for them, right? This is the notion we all know. This helps us uncover the daily addressable struggles, helps staff members know what's possible. But first, I would argue they need to understand that the physical environment is a spatial lever, and it can be manipulated to solve their problems. And that can only happen if they know what to expect from the building. And I think this is truly a fundamental issue, which is to say, teaching what design can do. Do they know that design can reduce infections, errors, and falls? That clinical staff play a crucial role in whether planning and design efforts succeed, right? They experience the challenges and success on a daily basis. So we need to teach them. And this is just a spectrum of the different outcomes that one should be expecting from a building. We've got here a great paper if you don't know it. We do need to redo this one. If anyone is interested in undertaking a massive endeavor on a lit review of the latest in evidence-based design, but this is still a great primer of what design should be able to do. And it's not just the clinical people, right? It's HR. I mean, if we're thinking about teaming behavior, that's a human resources problem. It's the C-suite, it's nursing leadership, it's the staff nurses. So instead of just gathering feedback on what people want, which quite frankly, nurses and doctors only know their current milieu, and it's really hard to get them to think about what could be, what about focusing on educating them about what good design can do and how it can improve their work, right? And so as our options increase, it's important to know what works and adds value rather than getting lost in the abundance, if you will, of choices. Quality improvement can also play a role here. The initiatives can start to take into account these physical environment factors. I can't tell you how often I will find some sort of QI event that 100% has a built environment component to success or failure, and it's just lost because healthcare people just don't see the space around them. It's part of who they are, and they don't consider it as something that they can manipulate. Part of this, I think, is building a shared mental model. The SIPS model, if you don't know this paper by Carry On, there have been several versions since, but this is the classic one. I strongly recommend you take a look at this. It breaks apart the work that we do into three separate parts. There's the work system on the left, there's the processes, and then there are the outcomes. And under the work systems, you'll see that there are 5 levers that we can pull, right? We have the people in the middle, tools and technology, the organization, the tasks, and the built environment to separate it out, right? And the model here you can see involves the entire team, right? Those who plan and manage the work across all those folks. Now, the reason why I think it's critical to suggest and to help one understand the physical environment component here as one lever is oftentimes I hear from designers who fret about this being, stuck holding the bag, if you will. The building isn't working. There are complaints about this, that, and the other. Oh, well, something must just be wrong with the design. I would remind my fellow clinicians and those of us who are owners and operators that there are 5 levers, right, that affect the processes that then affect the outcomes that we're looking for. The built environment is but one, right? So there's a full responsibility across the entire work system to make the work work. So turn into the planning phase, designing in scenarios. In Learnings from the Long View and a book called The Art of the Long View, I highly recommend that one too, by Peter Schwartz. He's famous for his work on scenario building. And part of his narrative is that failure is most often found when the planners didn't attend to the deepest concerns of the people who are doing the work, right? And the deepest concerns are often around these operational issues or patient uncertainties, right? Now, as we've already discussed, we do our best to understand operations. We have extensive spaghetti diagrams. We map out the typicals. We look at the route to clean supply, the medrooms. But these diagrams don't capture the coping that will take place on a daily basis. So, like, what are the deepest concerns of our clinicians, right? I would argue, do you have good visibility in the emergency department? What does optimum and suboptimum work look like? Can the layout work well when you're short-staffed, as well as when you're fully staffed? Right? What happens? Can the facility management adjust the environment to new safety protocols? How easily is it for them to do that as opposed to routine maintenance activities? So these sorts of things, attending to the deepest needs, not just the codified work that we know will happen, but all the little in-betweens that, quite frankly, we can reasonably start to codify and to list out, right? Because they happen all the time. So by an example, Peter Wack, furthermore, who's a former lecturer in scenario planning at the Harvard Business School, he outlined an approach that argues that we should accept the uncertainty, attempt to understand it, and make it part of the reasoning for decisions. So by doing that, it addresses the real concerns of the managers and the staff. Now, in the hospital setting, understanding the deepest concerns can certainly lead to better outcomes, right? Whether these concerns are related to crisis modes, hand hygiene, safe medication practices, visibility in the ED. But if the designs don't resonate with the people's needs, they may in fact fail if that isn't the concern. So we can start to shape the decision-making environment of healthcare professionals by influencing how nurses, doctors, and managers think about their work environment and the operations, right? So instead of just focusing on getting the physical design of the hospital or the system perfect, right, which is, again, as we've already discussed, is not really going to be possible, it's about tailoring an adaptive approach and a solution to fit the unique concerns, needs, and dynamics, right? So if we understand the scenarios and address the real needs of the healthcare teams, we can help them create environments that better support their practices and better support their outcomes. So focusing on the everyday, right? So instead of imagining the just perfect scenarios where everything goes smoothly, it might be fascinating if we instead focus on the realistic scenarios that challenge decision makers on an everyday basis to rethink an understanding of how things work. Now, everyone has biases, and I'm not suggesting, that the one doctor who remembers that one big event and that somehow we're going to design an entire unit around, that one worst case scenario. Certainly not suggesting that. But these scenarios can help us think about the everyday small challenges, being short-staffed, managing a new employee, dealing with a difficult family member, having multiple patients need attending at once. Different layouts will profoundly affect whether or not you can do that well, right? So, and we can even start to think about it very precisely. You're short a staff member or two, you have to revert to paper charts when your electronic health medical record goes down. You have patients in hallway spots, right? The charge nurse has to take a patient, right? Someone is violent, a staff member needs help. These are things that we can start to quantify and imagine. And I think that space syntax can really help us do that. This is a diagram of a hospital unit that I studied some time ago. And I can see, for example, and I'm thinking you can see my mouse, that the ability of the nurse to supervise and to handle being down a staff member or to supervise a violent patient is very different than if it's in this room, right? Because you're isolated. Who's going to be able to help you if you're down a staff member? So, someone has to leave, someone gets sick. I once had to leave in the middle of the shift. I started getting violently ill and I had to go home. That can happen, and there isn't anyone available to pick up the slack. So thinking about how our layouts will work when we are not at our template settings is really critical for how we imagine scenarios that will last. So as we think about this, lastly, just to conclude, designing the space to respond to the everyday occurrences and mishaps, we want to also design for the everyday, right? This is the next phase we're going to be talking about, the everyday. Now, you may be familiar with the Nielsen Norman Group. I really like their work. You can Google them, you can find them online. They mostly focus on product and UX design, but have fantastic framings for how we know whether or not a layout or a product is useful. And so usefulness, the way that Dr. Jacob Nielsen describes it, he describes it based on having two characteristics, utility and usability, right? And the usability and utility are equally important, right? And together, they determine whether or not something is useful, right? It matters little that something is easy if it's not what you want, right? And it's also no good if the system can hypothetically do what you want it to do, but you can't make it happen because the interface is too difficult, right? So while this framework is most often applied to product design, it's incredibly applicable to built environments and constantly reminds us to keep our stakeholders in full focus. So as I give examples here, utility doesn't have what people need. So utility refers to the design's functionality, right? Need. And it takes us back to our earlier conversation about meeting the deepest concerns of the workers. So as we think about people's needs, how can we be specific about what needs to happen in the space to help us assess its usefulness? And we can be really specific and avoid generic, terribly overused words like innovate or be flexible, right? I mean, I just can't use these words any longer. So for example, does it allow us to be aware, to supervise others, to counsel a fellow clinician, or to counsel a patient? Very different activities. To correcting an error, whether you're in the moment, whether someone can see you making the error, or whether you need to be involved in correcting, right? Performing. And by performing, I mean procedures, but also the performance of patient care, of demonstrating availability, of being present in the nursing unit. You know, when I think about doctors and nurses, when we're in, sometimes we'll have private charting zones that are not in the nursing station proper, but have glazing so that the patients and families stop asking where the doctors are, right? They are performing in a way, right? Showing that they are there to work. That's part of it. Does it allow us to document? Documentation, of course, comes in many forms across many platforms. I've recently started working with with several clinicians who have experienced technological shutdowns because of hacking or what have you. And the older nurses know how to use the paper charts and the flow charts. The more novel, newer nurses do not. So thinking about what documentation looks like, what do we do if we have to go back to that? Teaching, not only the passive teaching that happens, not only the active teaching that happens if I'm actively showing, this is how you do this, that, and the other, but the teaching that happens passively. This is a critical importance for how we work, right? As a nurse practitioner, I would be talking to nephrology, and staff would be nearby that can hear that conversation and learn as well about the patient, about the disease process, even if they're not actually active in that conversation itself. It's sort of passive tacit learning. The learning itself, which we talked about here. Testing, right? Do we make it easy to test out different ideas? Now, and I don't mean, and there's a lot of, debate about this, right? That there isn't room for testing in healthcare because of the risks associated and, of course, the requirements that we think about patient safety first. But I promise you, we're testing out little hypotheses all the time with changing patient medication, making adjustments to protocols based on the family need, based on the patient type. Small moments of testing. Why don't we include our environment in that? Testing whether or not our environments can be made better. Adjusting is certainly part of that, right? Whether it's adjusting our work or adjusting our environment. Adding, subtracting, right? To our work, to our building, to our process. So utility, does it have what the people need? And then usability. How easy and pleasant are the design's features to use? Right, so focusing on usability is a really good way for planners and designers to evaluate the design and address the common, like, who on earth came up with this complaint? Now, part of this certainly is about documentation, right? And something certainly is often questioned, but maybe shouldn't just be questioned because I didn't happen to be the one to do it. But the obviousness, right? That's part of it here. How easy and pleasant is it? How easy and pleasant is it easy to, forgive me, how easy and pleasant is said design to use, right? This should, if done right, transcend individual, right? Because it should be natural to the human. So usability is traditionally associated with 5 main attributes. I'm going to go through these. And again, I strongly encourage you to look at Nielsen's work. But the first is learnability. How easy is it for people to accomplish the basic tasks the first time they encounter the design? Right? Is it obvious? And we find this all the time. Like, do you really need to teach the patient how to do said thing? Or if a new nurse comes on the unit, it really is difficult to understand the layout and how it's working. And efficiency. Once people have learned the design, how quickly can they perform the task? Right? Is there a big delta where there's the learning period, if you will, right? Or are new staff quickly oriented to the design intention and get going? Or does the environment give us something else we have to learn, right? It's this intuitiveness of this efficiency that allows us to naturally understand the design. Memorability, critical one. When people return to the design after a period of not using it, how easily can they reestablish proficiency? How many of you have gotten lost in the bowels of the hospital? I have taken patients on numerous field trips on stretchers around the hospital because I couldn't remember how to get to MRI. It's really hard to find sometimes, right? So this is a question for a layout. It's a question for a UX design. It's a question for new staff or staff that are floating. If you've never been to a unit before, is it obvious how it works? Or if you're returning to it and you haven't been there in 6 months, can you quickly pick up again? Or do you start from the very, from the very beginning? We can also think about this in terms of patients and families. Oftentimes, you may go to a clinic once a year if you're a healthy individual, right? So when they return for their quarterly or their yearly visit, can they remember how the system works, how to get to their appointment, or where the bathroom is? Like, as we look at the floor plan, we can start to begin to predict where this natural centrality exists. And you can see on the right, again, starting to use other measures in space syntax to help us measure empirically from a wayfinding and layout perspective whether or not our building is memorable. On the error side, how many errors do people make? How severe are they, right? And how easily can they recover from the error, right? Are there signs, for example, telling patients not to enter the staff area? I've seen this so often, right? It's clearly this moment that somehow the building, the design is communicating this is for everybody when programmatically it's not, right? So that's an example there. And then lastly, satisfaction. How pleasant is it to use the design, right? This is about delight, right? Can we delight our users? So when designing for the everyday, we're thinking about these things in terms of whether we can make sure that the design is actually usable. And then lastly, I would remind us to do what we already know we should. Some of you may be familiar with this work. In 2021, Dr. Ryan Stewart tweeted a request. This is a screenshot of his tweet on how to design an ideal visit to the gynecologist's office, and he got over 3,000 responses. Gowns for body types, warmer exam rooms, not getting news in the waiting room, having less harsh lighting, pamphlets with people of color, places to put clothing, stirrups away from the door. How many of you have heard all these things before, right? We've heard them before because we know what good looks like, right? But there's a delta between knowing what it looks like and actually doing what we know we should. And as things change, implementing a flexible design to support future unknowns. There may be new ideas about how to design this ideal visit in the future that we can't even conceptualize now. How do we make it easy to do that? So for example, when we're working with our clients and we're understanding how to handle a rowdy patient in the room, we can apply what we know, right? Like we do know some things like visibility to circulation and seated work areas to maximize eyes on. We can think about careful attention to ingress and egress. We can apply attention to the atmosphere, right? Is there a soothing environment? So sometimes there'll be a new issue, right? Some new problem or variation therein to think about. And so then, yes, we should explore new ways to handle those problems. But in many cases, we just need to implement, know the literature, and actually do what we already know we should. So during this occupancy phase, right now we're moving on in the process, as you can see, continuing to teach. How often have you, I wish I could see you in person, you've taught people how to use this space, and now you have a whole new group of people who've come on board, right? And they weren't a part of the initial education. They don't know what to expect from the building. And furthermore, they don't know how or why the building is working today, right, in its new state. And certainly new staff are coming on. If we look at turnover rates, which tend to be between 30 and 50%, you can anticipate that the nursing staff will be in this constant cycle of change. So that's an opportunity for architects, for designers, for support functions all across the system to remain engaged with staff to teach them how to use their building. So, and this will require, not just the onboarding when taking occupancy, but bringing along those people that are new. That way, they can maximize the functionality of the space and they can understand how the design can support patient care and continuous improvement. It doesn't, we don't start again with well, who on earth designed this question? No, it was very purposeful. Now, I often find that once we explain the purpose behind it, oh, I get it now, maybe that's an opportunity for change. Right? Maybe there is a new process that needs to take place, but understanding what the baseline intention was is critical if we want to then measure a change, right? How have we improved by making adjustments in our environments? So to help get the clinical staff get the most out of the environment, you can see here where we've talked about the planning phase, we're talking about the occupancy phase, teaching staff to use their space, and then in the practice phase, right? So many of you are engaged in activation or transition planning. It's a great first step, right? We all need reminders and updates on the key processes in our work. In healthcare, fortunately, and oddly enough in healthcare, we have yearly in-service trainings and checkoffs where you're actually not allowed to see patients unless you're double checking that I know how to use the insulin pump that I use every day. But that's what we require to do, right? To help remember how to deliver safe care, right? That being the outcome we're looking for. But in this case, again, safe care to remember how to get the most out of their built environment, right? To prevent the workarounds, to teach them how things could be used and avoid the who thought this was a good idea issue. I can't tell you how often I've gone back to a unit, my unit that I actually was participating in the design of years and years ago at Emory. I see patients every day and I would notice that people would forget. How did you know this could adjust? People don't remember, they just suffer through it, right? So this is also a good moment to get real-time feedback when you're engaged in the updates, if you will. What's working, right? What is meeting the deepest needs? What's meeting the deepest concern? How did it go, right? When you had that, really squirrely patient in room 24579, right? These crazy room numbers. How did it go? What lever could we pull? Sometimes it is a built environment lever. Sometimes it's not. Sometimes it's people, process, place, or technology. I'll never forget when I was finishing my doctoral work, and I found that patients were more likely to survive based on their room location. And my physician, who was part of my committee, said to me, I couldn't leave it that way. He was in charge of quality. You have to help me solve for this, right? And it wasn't an environment issue because they could not make a change to the layout, right? We know that no building is perfect. Sometimes you have a not great room because that's just the way it is. So what do you do in that case? You pull a people lever. Maybe we increase the staff, right? In that particular part, like we do assignments of staffing differently. Maybe we change our rounding processes and we know that we have to have people revisit that part of the unit more often because we know that there's less supervision there. Maybe it's about adding technology, right? Where we use latest in AI to understand when that squirrely patient is starting to, and this does exist now, when they're starting to edge off the side of the bed. There are multiple ways that we can think about other levers to pull than the built environment when we're needing to adjust to meet the current needs of care. So these are all opportunities for us. So when we think about this phase education plan, thinking about it here, we've sort of pulled it out in these three sort of phases of where the teaching could take place. So again, in the planning phase, helping the staff, HR, facilities, understand what the environment could do, what they should expect, and about making choices related to evidence, right? If there's a lot of evidence for something, choosing that potentially over something that has less evidence. The next is teaching them how to use their space. I do this all the time, right? And I'm sure many of you do as well. Teaching them how to engage with their space. What was it designed for? We know that oftentimes the people who are occupying a space were not the people who designed the space. So that can also be important. And then in an ongoing way, reminding staff what their space can and should do for them. So Lastly, we're going to talk about tending to the building, right? So tending is a state of mind that thinks of modifications as a positive approach to environments, right? It's this active state of constant adjustment and nudging into a desired direction. Now, I'm going to show you these authors, their names in a second. May I highly encourage you to read this piece. They argue that the form that we are designing should always prefigure its next state. Let's think about that. We are going to prefigure the next state, like always thinking about what we're designing now in terms of what it will become. Right? So instead of fixing or abandoning, we think about an approach as an ongoing experiment to continually be tested in search of a better result. So we make changes, we try adjustments, we put a design in place that anticipates the next state. So again, I strongly encourage you to look at the Places Journal. If you don't know it, it is open source. It is a public academic journal, if you will. Academicians and practicing designers from all over the world participate and submit to it. It's urbanism, architecture, city planning. Fascinating journal, free. Do have a look at it. But in this case, Keel Mo is a practicing architect based in Vermont. And Dr. Daniel S. Friedman is a professor in the School of Architecture at the University of Hawaii in Manoa. And they authored the second in a series of articles titled The Repair Manual in the Places Journal called Tending Building, right? Where they argue that to tend a building is to design in consonance with inevitable change. And you'll love the example they use. So please check it out. Let me know what you think about it. It's just fascinating. But the notion is that the practice of tending moves beyond the misleading. This is fascinating, right? The misleading distinctions between new and old. And one question that I've had when sharing this with designers and owners across the country is this: how long after you've opened your new building does it become part of your existing portfolio, right? That thing that you have to deal with. And I've heard from some people within a month. Within a month, it's part of what they have to deal with and attend to all the desired, rally and call for change, right? So the time when we disconnect between form and function emerges, right? When should-haves reveal themselves, right? So this is where the tending can be so powerful. So, and yes, from a budgetary perspective, monies can be in different buckets, but if we plan with tending in mind, it can make a difference in terms of the markers for success, right? So again, this notion of moving beyond new and old and an attitude of constant care. And just before I move on, I would like to point out that we use the term tending in patient care. We tend to our patients. And what does that mean? The correlation is so beautiful with design and with architecture, which is to say that we are slowly making small changes to the betterment of the outcome. And we move up, we move down, we move left, we move right. We adjust according to what the response is, but we tend to heal. We tend to make better, and we know that it's a constant moving target, right? It never is resolved. And I think that is the key thing here. Again, with financial um, uh, goals in mind, of course, there is this notion of being a good steward. But I would argue that being a good steward means that this has been considered in the past so that it is a part of the thinking and a part of the spending. So to attend here, tending over time, you could argue that the POE is designed to identify failure. And I've seen institutions be concerned about the POE because you build the most perfect plan and the people, the processes, and technology shift. And then you find out what didn't work 9 months later, right? And in some cases, you've known right away, but no one has the psychological margin, the financial margin to actually address this. And so, I started playing with this notion and proposing here, might we consider an ongoing occupancy evaluation, right? Where small moves are possible and adjustments are low risk and low cost, right? And it opens the eyes of our customers, right? Of our owners, of our constituents to an expectation of adjusting their levers, spatial, procedural, technological, related to people, and using passive and active data gathering to know in real time. right? To know in real time what is making a difference instead of having to go in with our clipboards and this, this massive effort to decide once and for all, yep, on this date and time, it worked. Does that mean it works 6 months from then? Gosh, not necessarily so. So, right. So you can see that tending cannot begin with the sort of maintenance and repair that follows a building completion, but rather is during the design and planning process, right? It precedes construction. It is a framing of mind that we tend to our building. And so putting it into practice, suggesting that you look for organizations and partners, quite honestly, right, that help you with this planning and design expertise. So work with folks who are experts in imagining different ways that one can do this, bringing in lean and continuous improvement expertise. I'll never forget, it was so unfortunate, a project I was a part of as a clinician, as a staff member, where the lean people came in like 2 weeks before we opened. I mean, I just have no words, right? This is 25 years ago, so no doubt you all are much better now. We are all much better now, but that was certainly the case back then. Rather unforgettable. That we think about materials, product, and design education and instruction together, right? They need to work in concert together. The materials are tending, and please, if you do go back to that Places journal, the primary tending question they have is related to a material, interestingly enough. And then lastly, designing with change in mind. And so the forms we build can't be about perfection, right? It's this unattainable notion. So instead, let's build a plan that assumes tending will take place, design that empowers the operators, clinicians, and facility, right, to know what to expect and what levers to pull. And then hopefully sustainably, financially sustainably too, right? And perhaps for the first time, allow form to follow function. And that's the end. Thank you so much for your time. I really appreciate it, and I look forward to any questions. And am I still sharing? I am not. All right. There we are.
Thank you, Michelle. That was great. I don't see any existing questions, but I do have a couple that maybe I can throw out there that might maybe start our conversation going. And please, if there's any, oh, here's one. How do the content contribute to sell more furniture to our clients?
You mean that you want to know how we can sell more furniture?
That's what this question is. Yeah.
Now that the CU is finished, I would love to meet with Lucas. If you will send me an email later, we can certainly have this conversation. I would happy to work with you on that question. But since this is a CEU, you can see that the content is rather broadly applicable. It does apply to what you're asking, but I'll address that with you later if that's okay. And yes, we are happy to provide the links to the publications. That is not a problem, I think, again. But do just check out Places Journal in general, whether or not you want this particular article or not. It's masterfully done.
Michelle, if you are, let's say there's not an opportunity to have a major renovation, are there opportunities for tending that exist today that might help better align the building's form with its current function?
I think so. You can't always start a greenfield space, right? I mean, that's, we often, and it's unfortunate in healthcare design, and I think in research, we have a conclusion, everybody go do it. Didn't you know that things are so much better if you do it this way? But you're stuck with what you've got, right? I mean, we all know how difficult it is, how expensive it is to completely redo a unit, much less a building. And sometimes, I think about our Northeastern friends, for example, living in old cities. I mean, you're not going to make a city block bigger in New York. I mean, that's just not going to happen, right? So instead of focusing on built environment, or let me rephrase, using the built environment and thinking about the tools together, I think too often we move to built environment because our clients move to built environment because then it becomes that problem, right? It's not about that we haven't staffed appropriately. It's not about that we haven't thought about signage and so we can't see any patients because we have blocked every visible window with instructions about go in the room, not go in the room, who to call, where they are with their ins and outs. It's, there are multiple levers to pull. And so, I would genuinely suggest bringing the SIPS model, the article, Carry On, Carayon, Carry On, famous. They're on version 3 now. Of this model, which clinicians are often very familiar with because it's a human factors model. And it supports helping clinical people think about the full system that will get them to their outcome rather than just focusing on the built environment, which again, in some cases, one cannot make a big difference. Let's see, any hospital I find, I can see the questions now.
Okay,
Is there
good.
any particular hospital that you find to be the most successfully designed? Oh, wow. Wouldn't that be magical? I did see a beautiful hospital. I just saw one, Ascension in Indianapolis. They just completed a brand new mother baby. For those of you who are at healthcare design, it was one of the spots that we got to go have a look at and see. Beautifully done, where they really thought about multiple ways for clinicians to interact in terms of teaming, different ways for clinicians to separate and pull back from the general din of the unit, but have glazing so you maintain visible presence, right? You're performing, but still being behind the screen, if you will. A consideration for families, like we usually, and of course, it's mother baby, so you tend to have that. A larger anteroom. I've not really seen this before. They truly built an anteroom to each room to house all the equipment so that it's out of sight, out of mind. Now, this is Indianapolis. They had land, right? They had land. Now, they had to carefully fit it in the land, but they still had land. But a beautiful spot. If you haven't seen it, I think it's called St. Vincent's. What I would look for. Let's see, a UX design rule. I don't know if you can look at these two, Jennifer. Anything that you think that are great? Oh gosh, we're getting lots of questions now. Let's see. I see the UX design rule is that designers are not users. Spending time in researching user profiles is key to save costs. I think that's a very excellent point. It can be an issue when we imagine ourselves as understanding how the work will be. And every hospital has its own set of population, right? The population is very different. And understanding what the families are like, what the patients are like, what the staff are like. And so, yes, I think using user profiles is a great way to do it. I also, however, encourage you to look at a study. So, for example, I could spend time talking with 10 nurses about the issues related to teaming in a med-surg unit. I could also look and see all the studies that have been published on that same question. And all of a sudden, I have a sample size of several hundred, right? So it lets me move beyond the biases of the people that are focusing, like that I'm designing for. And this is where the education part is. It's to help them see, yes, this is your current reality, and this is your deepest concern, to your point, right? It's your deepest concern. Let's look at what research has been done to actually address that question. Do you disagree? If you disagree, great. Maybe we should do a research study. There's something new here, right? They are incorrect in the literature. Things have changed. But if not, and oftentimes I think you'll find, if not, that literature can help support that work and give more evidence to the 10 nurses that you spent time really deeply understanding. So I do think that's a critical point. And I'm so glad you brought that up. Designers are not users.
Do you think it sounds like the staff Michelle really can have a lot of influence, especially when supported by research? Had you experienced any examples that led to significant change or improvement when staff feedback was taken into consideration?
Oh, 100%. 100%. The last time, I could think of certainly ones that are related to my work at MillerKnoll, but seen where, now let me say, it can happen for the good or for the bad, right? We all know this, where we have a doctor who brings in a lot of money and they get their suite the way they want it, whether or not the evidence actually supports them having that private office, which it doesn't, right? So there is the good and the bad, but I do think it's important to share the data with them. This is what the data suggests about we can give you a private office. Let me show you what the data suggests about the quality of conversation you'll have with your teammates, the frequency with which you will catch mistakes and errors, the ease of scheduling. Like, I want you to think about your everyday and the private office. Maybe we do some sensors and we see how often are you actually in that private office? And then maybe we make some changes. So that's on the negative side. On the positive side, yes, I've seen it where, a particular nurse may have a great idea, but they don't know what the evidence is to support that. And this is where architecture and design, we can play a role in providing that evidence. Because remember, nurses and doctors, they're not familiar with the architecture literature, and they don't know how to operationalize a variable. So what I mean by that is they may have difficulty communicating with, let's see, another nurse. They can never find anybody, but they may not know that that's actually something we measure with view sheds, right? We measure with distances. We measure, like, there are many ways that we can start to measure that spatially to help them have more emphasis and oomph behind their need, right? That's spatial.
Seems like really the only thing we can, ever really rely on with change, with technology, with planning is this idea of change. Do you have any thoughts on maybe strategies that you could consider or offer to keep facilities adaptable and responsive to future changes?
Oh, yes. I often hear that there's this concern that more adaptability is more expensive. I think that there is a threshold. Does everything need to be movable? Of course not. Right? That's just silly. I often say that infinite flexibility is not flexible at all, right? Because then there are just way too many options. So, for example, I have certainly worked with systems where we think about, here are 5 or 6 different ways you might you might lay out this space, or that you might adjust this space with what you have. You might need to add or subtract a little bit from the kit, if you will, whether it's furniture, whether it's moving a wall, whether it's technology. You might add or subtract a bit, but generally speaking, you know what the options are. And I think that we do know enough in terms of our hypotheses to have a set of 5 or 6, scenarios that we can imagine where that goes. So yes, I do think that's entirely possible. The other thing is to not just in the specification process when we're at that point, but also it does mean that we change some of the way we think about budgeting, creative budgeting. I understand the systems and the way that they work, but we also have the ability, or shall I say, administrators also have the ability to move things around if they want on the spreadsheet to account for these small changes later. And I think being thoughtful about that can open the door to help make that possible. I know that we're asking for a lot, right? Administrator, change how you think about your budgeting. But if we keep everything in the initial spend bucket, we're not going to be able to make the changes that we need ultimately. The outcome is the goal. And so maybe it's just a matter of, I would encourage anyone here to publish the study. Try a little pilot. You're making a little change, reserve it. What does that allow you to do if you have margin, right? Not just psychological margin, financial margin too.
Balancing upfront cost with long-term value.
Yeah, they're nicely said. Yes,
You know,
Jennifer.
so pilots are a nice way if you have time to
They
do
are.
that in your
They are.
existing
They are. They
facilities.
are. Well, and then the other thing I would say, publishing it. I mean, the reason why everyone has to do their own at the beginning is because no one shares. If you don't want to have to do that every time, then we need to start sharing with each other and being open about what works and what didn't. What I find most folks want is to avert risk. And the only way we can avert risk is through sharing how it went. Fortunately in healthcare, our goal is to improve the lives of patients. I'll never forget during COVID, you saw a Mass General in Cleveland Clinic on Twitter posting photographs of whiteboards of the care plans, like how exactly it was that they were treating patients for COVID on ventilators because no one knew how to do it. They didn't keep it to themselves and like, only the people who are at Cleveland Clinic will survive. Of course not. They were sharing everything they had to help improve the lives of others. We need to take that same attitude here.
Makes sense.
See, I think we're just about up. Gold standard checklist. Yes, for those of you who don't know, I strongly encourage you to tap into the Center for Health Design. They have amazing, detailed checklists and post-occupancy evaluation tools that you can use on the front end, so you know what you want to design for, right? All evidence-based, cited to beat the band. It's a beautiful place to start. Those folks spend a lot of time making sure that they keep it current and that they keep it relevant. So I would strongly encourage you to check that out.
Perfect.
See. I don't think we have any time.
Last one is, do you find with planning for clinicians, more mobile touchdown areas for versatility is helpful?
Yes, yes. Most certainly, because they're always trying to move around over and over again. I have multiple photographs from systems all over the country where I will find some doctor or some nurse who has found a Mayo stand or some other small little table to make a randomly located place to document. And I would argue that it's not so randomly documented. It's placed so that they can either stay in front of a patient they need to see, be able to make sure they catch said doctor when they come out of a room or are going into a meeting. I mean, it's very interesting to see where people move these places to document and to chart. There are all sorts of things that come into play. Mobility is the best way to let them have that.
Wonderful. We're just about at time here,
Yes, thank you
and
all
there
so
may be some
much.
additional questions that pop up. You might get a project, in the near future that all of a sudden that starts to percolate and you have some questions. Please reach out to your local healthcare representative in your market. You can certainly tap into Michelle Ossmann at
Yeah,
MillerKnoll.com as well. But you should have a local representative as well. And we're happy to kind of continue this conversation and help you facilitate great planning and facilities as you move forward. Let
sounds
us know
great.
how we can help.
Thanks,
Thank you,
everyone.
Michelle.
Have a great day.
Bye, everyone.